Welcome to Huberman Lab Essentials, where we revisit past episodes to highlight the most potent and actionable science-based tools for mental health, physical health, and performance. Today, we're diving into my conversation with Dr. Karl Deisseroth, a world-renowned neuroscientist, psychiatrist, and pioneer in the field of optogenetics. Dr. Deisseroth's work bridges the gap between cutting-edge laboratory research and clinical psychiatry, offering profound insights into how the brain functions and how we can treat mental illnesses more effectively. In this episode, we explore the differences between neurology and psychiatry, the challenges of diagnosing and treating psychiatric disorders, the potential of emerging technologies like optogenetics, and the future of mental health care. Let's get started, Huberman. Well, thanks for being here, Karl. It's a pleasure to have you. Deisseroth, thanks for having me, Andrew. I'm excited to be here and discuss these topics with you. Huberman, let's begin with some foundational concepts for those who might not be deeply familiar with neuroscience or psychiatry. Could you explain the key differences between neurology and psychiatry? These fields often get conflated, but they approach the brain and its disorders in distinct ways. Deisseroth, absolutely, it's a great starting point. Neurology and psychiatry both deal with the brain, but they focus on different aspects of its dysfunction. Neurology is concerned with disorders where there's a clear, measurable, physical abnormality. For example, a neurologist might diagnose a stroke by observing it on a brain scan, or they might detect seizure activity using an electroencephalogram EEG. These are tangible, quantifiable markers, something you can point to and say, this is the problem. Neurologists are trained to identify and treat conditions like epilepsy, Parkinson's disease, or multiple sclerosis, where the pathology is often visible or measurable through imaging, blood tests, or other diagnostics. Psychiatry, on the other hand, operates in a much more mysterious realm. It focuses on disorders where we don't yet have clear physical markers. There's no blood test to definitively diagnose depression, schizophrenia, or autism. There's no brain scan that says, this is bipolar disorder. Instead, psychiatrists rely on words, descriptions of symptoms, patient histories, and behavioral observations. We use standardized tools like rating scales to quantify things like depression or anxiety. But at the end of the day, these are still based on verbal reports and subjective experiences. It's a challenging field because we're trying to understand and treat the most complex object in the universe, the human brain, using tools that are, in many ways, indirect. This distinction creates a unique dynamic. Neurologists often have concrete data to guide their treatments, while psychiatrists must navigate a landscape of ambiguity, relying on their clinical intuition and the patient's ability to articulate their inner world. It's both an art and a science, and it requires a deep understanding of human behavior and emotion. Huberman, that's a fascinating contrast. It sounds like psychiatry is almost like detective work, piecing together clues from what patients say or don't say. Since words are your primary tool, does the patient's verbal ability affect your ability to diagnose them? For instance, is it easier to diagnose someone who's very talkative and expressive, or does that sometimes complicate things? Conversely, what happens when someone is quiet or reserved? Deisseroth, you've hit on a critical point. In psychiatry, words are our currency, so the patient's ability to communicate does play a significant role. If a patient is highly verbal, it can provide a wealth of information, sometimes too much, as they might flood you with details that obscure the core issue. Hyperverbal patients, such as those with mania or certain personality disorders, can be challenging because their speech might be rapid, tangential, or disorganized. You have to sift through the noise to find the signal. On the other hand, patients who are quiet or reserved pose a different challenge. A lack of speech can itself be a symptom. For example, in severe depression, people may become so withdrawn that they barely speak. In schizophrenia, negative symptoms like reduced speech or emotional flatness can dominate. In autism, some individuals may struggle with verbal communication altogether. When speech is limited, we rely on other cues, body language, facial expressions, or even the patient's history from family members or previous records. But yes, in principle, less verbal input makes diagnosis harder because we have fewer data points to work with. There's also an art to drawing out information. With a reserved patient, a skilled psychiatrist might use open-ended questions, create a safe environment, or even sit in silence to allow the patient to feel comfortable sharing. Sometimes, the absence of speech tells you something profound. For instance, a patient with catatonia, a state where they're nearly immobile and mute, might be experiencing severe depression or a psychotic episode. Distinguishing between these possibilities requires careful observation and, often, collateral information from others who know the patient. This variability is part of what makes psychiatry so complex. Every patient is a puzzle, and the pieces you get to work with depend on their unique presentation. It's why building trust and rapport is so critical. It's not just about getting answers. It's about creating a space where the patient feels safe to share their inner world, however they're able to express it. Huberman, that's really insightful. It sounds like you're not just listening to the words, but also interpreting the silences and the spaces between them. Given that psychiatry relies so heavily on subjective reports, do you think we'll ever have objective tests, like a blood test or a brain scan, for disorders like depression, schizophrenia, or autism? And if we did, would that be a good thing, or could it have downsides? Deisseroth, I'm optimistic that we'll eventually have objective, quantitative tests for psychiatric disorders. The brain is a physical organ, and psychiatric conditions at their core arise from disruptions in its circuits, connections, and chemical signaling. These disruptions are physical, even if we can't yet measure them with the precision we'd like. Already, there are promising developments. For example, researchers are exploring EEG-based approaches to identify specific brain wave patterns associated with disorders like depression or schizophrenia. These patterns, or biomarkers, could one day serve as diagnostic tools, much like an EKG for heart conditions. Other avenues include neuroimaging techniques, like functional MRI, which can reveal how different brain regions communicate in conditions like autism or anxiety. There's also growing interest in molecular markers, things like inflammation, related proteins, or genetic profiles that might correlate with certain disorders. These are still in early stages, but the trajectory is clear. As our technology improves, we'll get closer to measurable diagnostics. Now, whether this is entirely a good thing depends on how these tools are used. On the positive side, objective tests could reduce the stigma of mental illness by showing that these conditions are rooted in biology, just like diabetes or hypertension. They could also improve diagnostic accuracy, ensuring patients get the right treatment faster. For example, distinguishing between bipolar disorder and major depression can be tricky based on symptoms alone, but a biomarker could clarify the diagnosis and guide treatment. However, there are risks. Any medical test can be misused or misinterpreted. Imagine a scenario where a blood test for depression is used by employers to screen job candidates, or by insurance companies to deny coverage. There's also the danger of overdiagnosis, labeling people as depressed based on a test result when they're actually experiencing normal sadness or stress. And in psychiatry, context matters. A test result without a thorough clinical interview could lead to oversimplified or harmful conclusions. Ultimately, I think the benefits outweigh the risks, provided we approach these tools with rigor and ethical safeguards. Objective tests won't replace the human element of psychiatry. They'll complement it, giving us more data to work with while still relying on the clinician's judgment to interpret the full picture. Huberman, that's a balanced perspective. It's exciting to think about a future where we have more precise tools, but it's also a reminder of how nuanced this field is. Speaking of challenges, what do you see as the biggest obstacle facing psychiatry today, both in terms of understanding mental illness and delivering effective treatments? Deisseroth, the biggest challenge, in my view, is stigma. Despite all the progress we've made in understanding mental health, there's still a pervasive belief that psychiatric disorders are a sign of personal weakness or something people should just snap out of. This stigma prevents many people from seeking help, sometimes for years, which can worsen their condition. For example, untreated anxiety can spiral into depression, creating a more complex problem that's harder to treat. Early intervention is critical in psychiatry, just as it is in other areas of medicine, but stigma often delays that first step. This issue is compounded by cultural factors. In some communities, mental health treatment is seen as taboo, or there's a fear of being labeled as crazy. Even in more open-minded settings, people might feel they should be able to manage their emotions on their own without professional help. This mindset can lead to self-blame and isolation, which only deepens the suffering. From a scientific perspective, another challenge is our limited understanding of the brain's complexity. We've made incredible strides in mapping neural circuits and identifying neurotransmitters, but we're still far from a complete picture of how these systems produce thoughts, emotions, and behaviors. For example, we know serotonin plays a role in depression, but we don't fully understand why selective serotonin reuptake inhibitors (SRIs) work for some people and not others. This gap in knowledge makes it harder to develop targeted treatments with fewer side effects. Finally, access to care is a huge barrier. Even if someone overcomes stigma and seeks help, they might face long waitlists, high costs, or a shortage of qualified providers. This is especially true in underserved areas or for complex disorders requiring specialized care. Addressing these challenges will require a combination of public education, scientific innovation, and policy changes to make mental health care more accessible and equitable. Huberman, stigma is such a pervasive issue, and it's heartbreaking to think about how many people suffer in silence because of it. You mentioned something earlier that struck me, which you've also talked about in past lectures, the idea that we don't really know how other people feel, and sometimes we don't even fully understand our own emotions. Could you elaborate on that? As a psychiatrist, how do you navigate the subjective nature of feelings when your job is to diagnose and treat based on what patients tell you? Deisseroth, this is one of the most profound and humbling aspects of psychiatry and of human experience in general. Emotions are deeply personal, and while we have words to describe them, those words are imperfect. Take sadness, for example. We might use terms like blue, down, melancholy, or heartbroken, but each person's experience of sadness is unique, shaped by their biology, life history, and context. There's no objective yardstick to compare my sadness to yours, or to know exactly what you mean when you say you're depressed. In psychiatry, this creates a challenge because we're trying to translate subjective experiences into a framework that allows for diagnosis and treatment. When a patient says, "I'm depressed," we have to dig deeper to understand what that means for them. Are they feeling hopeless, lethargic, disconnected? Are they unable to enjoy things they once loved? To get at this, we use structured interviews and standardized questions that anchor the conversation in concrete experiences. For example, I might ask, how much are you looking forward to the future? Are you making plans? Do you feel hopeful? These questions help us move beyond vague labels and get to specific, observable patterns. There's also a linguistic divide to navigate. The words we use in the clinic, like depression or anxiety, have precise meanings in a diagnostic sense, but patients might use them more colloquially. Someone might say, "I'm so anxious," when they mean they're nervous about a specific event, not that they have generalized anxiety disorder. Part of our job is to clarify these terms and ensure we're on the same page. This process is further complicated by the fact that emotions are dynamic and context-dependent. A patient's mood might shift during a session, or they might struggle to articulate their feelings because they're not fully aware of them. This is where the art of psychiatry comes in: building trust, asking the right questions, and sometimes interpreting nonverbal cues like tone, posture, or eye contact. On a broader level, this question touches on a philosophical issue. We're all trapped in our own minds with no direct access to anyone else's inner world. Even in my lab, when we study animal behavior, whether it's zebrafish, mice, or rats, we can observe actions and measure neural activity, but we can't know what they're feeling. The same is true in human relationships, whether I'm talking to a patient, a colleague, or a friend. We rely on words, behaviors, and shared experiences to bridge that gap, but it's always an approximation. That's both the beauty and the challenge of studying the mind. Huberman, that's a powerful way to frame it. It really underscores how much skill and empathy it takes to do what you do. Let's shift gears to treatment. Are there any psychiatric treatments, whether medications, therapies, or other interventions, that are highly effective, either working reliably for most patients or producing dramatic results in specific cases? Could you share a few examples of psychiatry's greatest successes? Deisseroth, despite the challenges we've discussed, psychiatry has some remarkable success stories. Both medications and talk therapies have been shown to be highly effective for many conditions, often transforming lives in ways that were unimaginable a few decades ago. One standout example is cognitive behavioral therapy (CBT) for panic disorder. Panic disorder is characterized by sudden, intense episodes of fear that can feel like a heart attack or impending doom. CBT helps patients identify the early signs of a panic attack, like racing thoughts or physical sensations, and teaches them strategies to interrupt the cycle. By reframing their thoughts and practicing techniques like controlled breathing, patients can significantly reduce the frequency and severity of attacks. Studies show that CBT is effective for up to 80% of patients with panic disorder, and the benefits often persist long-term. It's a powerful example of how words and structured dialogue can rewire the brain's response to fear. On the medication side, antipsychotic drugs are a cornerstone of treatment for schizophrenia and related disorders. These medications, like risperidone or olanzapine, can dramatically reduce symptoms like auditory hallucinations and paranoid delusions. They're not perfect. They come with side effects like weight gain or sedation, but for many patients, they're life-changing. I've seen patients who were tormented by voices go from being unable to function to holding jobs and rebuilding relationships, all because of these drugs. It's a testament to how far we've come since the days of institutionalization. Another fascinating success is electroconvulsive therapy, ECT, for treatment-resistant depression. ECT involves inducing a controlled seizure under anesthesia, which somehow resets dysfunctional brain circuits. It's one of the most effective treatments we have for severe depression, with response rates as high as 70-90% in some studies. I've worked with patients who were so depressed they couldn't get out of bed or speak, and after a course of ECT, they were engaging with life again. It's not without controversy. There's stigma around it, and it can cause memory issues, but it's done under strict medical supervision and is far safer than it was in the past. That said, these successes come with a caveat. Our treatments aren't as precise as we'd like. A cardiologist can measure blood flow and pinpoint a blocked artery, but in psychiatry, we don't yet have that level of clarity about what's going wrong in the brain. We know ECT works, but we don't fully understand why. We know antipsychotics target dopamine receptors, but we don't know why they help some patients and not others. This lack of mechanistic understanding is frustrating, but it also fuels our drive to keep researching and refining our approaches. Huberman, those are incredible examples. It's amazing to hear about treatments that can make such a profound difference, even if we don't fully understand the why behind them. Building on that, let's talk about the future. You've spent decades studying the brain circuits and developing technologies like optogenetics, which allows precise control of specific neurons using light. In your ideal world, what would the perfect cure for a psychiatric disorder look like? What are the key components we need to get there, Deisseroth? This is a question I think about a lot, both as a clinician and a scientist. To create the perfect cure for a psychiatric disorder, whether it's depression, autism, or schizophrenia, we need to understand the brain at a level of detail that's analogous to how we understand the heart as a pump. The heart's function is clear. It circulates blood. If it's not pumping effectively, we can measure that and intervene. In psychiatry, we don't yet have a comparably clear framework for what each brain circuit is for, or how it contributes to complex behaviors like motivation, fear, or social connection. So, the first component of the perfect cure is a deep understanding of neural circuits. We need to map the specific cells, connections, and activity patterns that underlie healthy behavior, and then identify how those go awry in disease. For example, in depression, we know that areas like the prefrontal cortex and the ventral tegmental area, which is involved in dopamine signaling, are implicated. But we don't yet know exactly which neurons or pathways are malfunctioning, or how their activity differs from a healthy brain. The second component is the ability to precisely modulate those circuits. This is where technologies like optogenetics come in. Optogenetics allows us to turn specific neurons on or off with light, giving us unprecedented control over brain activity. In animal studies, we've used it to manipulate circuits involved in anxiety, reward, or social behavior, revealing how they work and what happens when they're disrupted. The dream is to translate this precision to humans. Imagine being able to tune a depression-related circuit like you'd tune a piano, restoring balance without affecting other parts of the brain. The third component is real-time feedback. The brain is dynamic, constantly adapting to new experiences and environments. A perfect cure would involve monitoring brain activity in real time and adjusting interventions as needed. This could mean implantable devices that detect abnormal patterns and deliver targeted stimulation, or even non-invasive methods like transcranial magnetic stimulation, TMS guided by advanced imaging. Finally, we need to integrate these biological interventions with the human element, things like therapy, lifestyle changes, and social support. A cure isn't just about fixing the brain, it's about helping the person live a fulfilling life. For example, someone with autism might benefit from a circuit-based treatment to improve social communication, but they'll also need support to navigate relationships and build confidence. This bento box of a perfect cure, circuit understanding, precise modulation, real-time feedback, and holistic support is ambitious, but it's not science fiction. We're already making progress in each area, and I believe we'll see transformative advances in the next few decades. The key is to keep studying the brain as an engineer would, breaking it down into its components and figuring out how they work together to produce the symphony of human experience. Huberman, that's an inspiring vision. It really feels like we're on the cusp of a new era in psychiatry. You mentioned optogenetics, which brings me to a specific application I've been curious about. In 2015, there was a New Yorker article about your work, describing a case where you used vagus nerve stimulation, VNS, to treat a patient with severe depression. The vagus nerve is this fascinating superhighway, connecting the brain to the body. Can you explain how VNS works and how optogenetics or related technologies might make it more precise? More broadly, where are we at with using these tools to treat psychiatric disorders? Deisseroth, the vagus nerve is a great example of both the potential and the limitations of current neuromodulation techniques. The vagus nerve, or the 10th cranial nerve, is a bidirectional communication pathway between the brain and the body. It sends signals from the brain to organs like the heart, lungs, and gut, regulating things like heart rate and digestion. It also carries sensory information back to the brain, informing it about the body's state. Because of this, it's an attractive target for treating disorders that involve brain-body interactions like depression or epilepsy. Vagus nerve stimulation (VNS) involves implanting a small device that wraps around the nerve in the neck and delivers electrical pulses. It was originally developed for epilepsy, where it can reduce seizure frequency by modulating brain activity. In the early 2000s, it was approved for treatment-resistant depression, based on evidence that it could improve mood in some patients who didn't respond to medications or therapy. How does it work? The honest answer is, we're not entirely sure. The vagus nerve connects to a brain region called the nucleus of the solitary tract, which is one synapse away from areas that produce serotonin, dopamine, and norepinephrine, neurotransmitters implicated in mood regulation. By stimulating the vagus, we're likely influencing these chemical systems, but the exact mechanism is unclear. It's a bit like turning on a light switch without knowing the wiring behind it. The challenge with VNS is its lack of specificity. The vagus nerve contains many different types of fibers, controlling everything from swallowing to breathing to heart rate. When you stimulate it electrically, you're activating all those fibers at once, which can cause side effects like hoarseness, difficulty swallowing, or even breathing problems. This limits how much stimulation you can safely deliver, which in turn limits its effectiveness. This is where optogenetics could be a game changer. Optogenetics allows us to target specific types of neurons with light, leaving others unaffected. Imagine if we could engineer the vagus nerve so that only the fibers involved in mood regulation respond to light. We could stimulate those fibers precisely without causing side effects like hoarseness or breathing issues. In animal studies, we've already shown that optogenetics can modulate specific vagal pathways, but translating this to humans is a big leap. We'd need to develop safe, long-term ways to deliver light, sensitive proteins to the nerve, as well as tiny implantable light sources that can be controlled externally. In the clinic, I use VNS with some of my patients, and it's a remarkable tool despite its limitations. I can adjust the stimulation parameters like frequency or intensity, using a radio frequency controller, tailoring it to the patient's needs. For example, I might increase the dose slightly while monitoring for side effects, then have the patient return in a month to report how they're feeling. It's not an immediate fix. The effects build over time, and not everyone responds. But for those who do, it can be life-changing. Looking beyond the vagus nerve, optogenetics holds promise for brain-based treatments as well. In depression, for instance, we could target specific circuits, like those in the prefrontal cortex or amygdala, that are known to be dysfunctional. Unlike drugs, which flood the entire brain with chemicals and cause widespread effects, optogenetics could activate or suppress just the right neurons, minimizing side effects. We're not there yet for humans, but clinical trials are exploring related technologies like deep brain stimulation (DBS), which uses electrodes to modulate specific brain areas in disorders like obsessive compulsive disorder (OCD) or Parkinson's. The broader challenge is scaling these technologies. We need to make them safe, affordable, and accessible, which involves everything from improving gene therapy techniques to designing user-friendly devices. It's a long road, but the potential to transform psychiatry is enormous. Huberman, that's incredibly exciting. The idea of fine-tuning the brain or body with such precision is almost mind-boggling. Speaking of neuromodulation, brain-machine interfaces (BMIS) are another hot topic. These devices, which can record and stimulate neural activity, are being developed by companies like Neuralink and others. What are your thoughts on BMI as a tool for understanding and treating psychiatric disorders? Deisseroth, brain-machine interfaces are a powerful frontier in neuroscience and psychiatry. At their core, BMI involve implanting devices that can either record neural activity, stimulate neurons, or both, creating a direct interface between the brain and external systems. They're already being used in research and clinical settings, and their potential is immense. From a scientific perspective, BMI are a game changer for understanding the brain. At Stanford and elsewhere, researchers are using arrays of electrodes to record from tens of thousands of neurons simultaneously, capturing the complex patterns of activity that underlie behavior. This is helping us decode how neural ensembles work together in conditions like depression, anxiety, or schizophrenia. For example, we might identify a specific pattern of activity in the prefrontal cortex that correlates with obsessive thoughts in OCD, which could guide new treatments. Clinically, BMI are already making an impact through techniques like deep brain stimulation (DBS). In DBS, a single electrode is implanted in a specific brain region, like the subthalamic nucleus for Parkinson's or the anterior cingulate for OCD, and delivers continuous electrical pulses. It's remarkably effective for some patients, reducing symptoms that were previously untreatable. What's exciting about BMI is the potential for closed-loop systems, where the device records brain activity, detects abnormal patterns, and delivers stimulation only when needed. This would be far more precise than current DBS, which is always on. For psychiatry, BMI could offer new ways to treat disorders that don't respond to drugs or therapy. Imagine a device that detects the early signs of a panic attack and stimulates a calming circuit in the amygdala, stopping the attack before it escalates. Or a system that monitors mood in bipolar disorder and adjusts stimulation to prevent manic or depressive episodes. These are still hypothetical, but they're within the realm of possibility as our technology improves. There are challenges, of course. Implanting devices in the brain is invasive, with risks like infection or tissue damage. We also need to ensure these systems are durable and can operate for years without failing. Ethical questions abound. How do we protect patient privacy when a device is recording their brain activity? How do we ensure equitable access to such expensive technology? Despite these hurdles, I'm optimistic. BMI are already helping patients with neurological conditions, and I believe they'll become a standard tool in psychiatry within the next few decades. Huberman, that's a thrilling glimpse into the future. Let's zoom in on a specific disorder that I get asked about a lot: attention deficit/hyperactivity disorder, ADHD. There seems to be a lot of confusion about what ADHD is, how it's diagnosed, and what can be done about it. Can you clarify what true ADHD looks like, and whether technologies like optogenetics or BMI might play a role in treating it? Deisseroth, ADHD is a fascinating and complex disorder, and it's no surprise you get asked about it so often. It's one of the most commonly diagnosed psychiatric conditions, especially in children, but it persists into adulthood for many. ADHD is characterized by difficulties with attention, impulsivity, and or hyperactivity that are inappropriate for a person's age and context. It's divided into 3 subtypes: predominantly inattentive, predominantly hyperactive, impulsive, and combined. The inattentive subtype might look like someone who struggles to focus on tasks, frequently loses things, or seems spacey. They're not necessarily hyperactive. Their mind is just elsewhere. The hyperactive, impulsive subtype, on the other hand, might involve constant fidgeting, interrupting others, or acting without thinking. The combined subtype has elements of both. What's key is that these symptoms must be pervasive, present in multiple settings, like home and school, and cause significant impairment in social, academic, or occupational functioning. Diagnosing ADHD involves a thorough evaluation, including interviews with the patient, parents, or teachers, and sometimes standardized rating scales. We also rule out other causes, like anxiety, learning disabilities, or sleep issues, which can mimic ADHD symptoms. One exciting development is the exploration of quantitative EEG-based diagnostics, where we measure brain wave patterns using a non-invasive skull cap. Certain patterns, like increased theta waves, have been linked to ADHD, and while these tests aren't yet standard, they could improve diagnostic accuracy in the future. Treatment for ADHD is well established and often highly effective. Stimulant medications like methylphenidate Ritalin or amphetamines Adderall are the first-line treatment, working by increasing dopamine and norepinephrine levels in the brain. They're effective for about 70–80% of patients, improving focus and reducing impulsivity. Non-stimulants, like atomoxetine, are another option for those who don't tolerate stimulants. Behavioral therapies like parent training or classroom interventions are also critical, especially for children, helping them develop organizational skills and self-regulation. As for optogenetics or BMI, they're not yet part of ADHD treatment, but they could be transformative down the line. ADHD is thought to involve dysfunction in frontostriatal circuits, which regulate attention and impulse control. Optogenetics could, in theory, allow us to fine-tune these circuits, enhancing activity in areas that are underactive. For example, we might stimulate neurons in the prefrontal cortex to improve focus without the systemic effects of stimulants. BMI could take this further, using real-time feedback to detect lapses in attention and deliver targeted stimulation. The challenge is specificity. ADHD symptoms vary widely, and we don't yet know the exact neural signatures of the disorder in each individual. Plus, these technologies are invasive and experimental, so they're not practical for a condition that's already treatable with safer methods. Still, for patients who don't respond to current treatments or who experience severe side effects, these approaches could offer hope. Research in animal models is already exploring how circuit-based interventions might improve attention, and I'm optimistic that these insights will eventually translate to humans. Huberman, that's a really clear breakdown, and it's encouraging to hear about the potential for precision treatments. One thing I've noticed is that many people wonder if they have ADHD, especially in today's hyper-connected world. With constant notifications, social media, and information overload, it feels like our attention is under siege. Do you think lifestyle factors like excessive phone use could induce ADHD-like symptoms or even exacerbate an underlying condition? Deisseroth, this is a question that's increasingly relevant in our digital age. There's no doubt that our environment shapes our brain and behavior, and the constant demands of modern life, phones, emails, social media, place unprecedented strain on our attention systems. These stimuli are designed to grab our focus, triggering small dopamine hits that keep us coming back for more. Over time, this can create a feedback loop where we feel restless or distracted when we're not engaged with a screen. Could this induce ADHD? It's unlikely to cause true ADHD, which has a strong genetic component and typically emerges in childhood. However, it can absolutely mimic or exacerbate ADHD-like symptoms. For example, excessive phone use might lead to difficulties sustaining attention, increased impulsivity, or a sense of mental clutter, hallmarks of ADHD. This is especially true for people with subclinical traits, where environmental factors push them over the threshold into noticeable impairment. Your personal example of a childhood tic is a great analogy. Tics, like ADHD, have a biological basis but can be influenced by stress, fatigue, or environmental triggers. Similarly, someone with a predisposition to inattention might find their symptoms amplified by a lifestyle that rewards constant tasks, switching. I've seen patients who describe feeling addicted to their phones, experiencing a buildup of tension until they check their notifications, much like the urge to perform a tic. This isn't ADHD in the clinical sense, but it can disrupt functioning in similar ways. The key distinction, as I mentioned earlier, is whether these behaviors impair social or occupational functioning. Checking your phone obsessively might feel distracting, but if it's not derailing your relationships or work, it doesn't meet the criteria for a disorder. In fact, in today's world, staying connected is often adaptive. It's how we collaborate and stay informed. That said, I encourage everyone to be mindful of their tech habits. Setting boundaries like designated screen, free time, can help restore focus and reduce that sense of mental overload. For those with diagnosed ADHD, managing environmental triggers is even more critical. A chaotic digital environment can make it harder to stay organized or prioritize tasks, so strategies like using productivity apps, minimizing notifications, or working in distraction-free settings can make a big difference. It's about creating an environment that supports the brain rather than overwhelms it. Huberman, that makes a lot of sense. It's reassuring to know that while our tech-heavy world might amplify distraction, it's not necessarily creating new disorders, just challenging our brains in new ways. Let's pivot to another topic that's generating a lot of buzz: psychedelic medicine. Compounds like psilocybin, LSD, and MDMA are being studied for conditions like depression, PTSD, and anxiety. What's your take on their potential, and what are the risks? Deisseroth, psychedelics are one of the most intriguing and polarizing areas in psychiatry right now. These compounds, psilocybin found in magic mushrooms, LSD, MDMA, and others, have a long history, both culturally and scientifically, and we're now seeing a renaissance in their study as potential treatments. The excitement is warranted, but so is the caution. Let's start with the potential. Psilocybin and LSD primarily act on serotonin receptors, particularly the 5-HT2A receptor, which alters perception, cognition, and emotion. Clinical trials have shown that psilocybin, when used in a controlled setting with therapeutic support, can produce rapid and lasting reductions in depression and anxiety. For example, a 2021 study found that psilocybin-assisted therapy was as effective as SSRIs for major depression, with benefits persisting for months. LSD has shown similar promise, though it's less studied. MDMA, which increases serotonin, dopamine, and oxytocin, is being explored for post-traumatic stress disorder (PTSD). Phase 3 trials have demonstrated that MDMA-assisted therapy can significantly reduce PTSD symptoms, with some patients achieving full remission. The FDA is considering approving MDMA for clinical use as early as 2024, which would be a landmark moment. Why do these compounds work? One hypothesis is that they enhance neuroplasticity, allowing the brain to form new connections and break free from rigid, maladaptive patterns. For depression, this might mean restoring hope and flexibility in thinking, countering the hopelessness and rumination that define the disorder. For PTSD, MDMA's ability to foster trust and emotional openness may help patients process trauma in a safe therapeutic setting. The subjective experience of psychedelics also seems to matter. Many patients report profound insights or a sense of connectedness during their sessions, which can reshape their perspective on life. This aligns with what you mentioned about psychoanalysis. Good therapy creates a space for transformative experiences, and psychedelics may amplify that process. Now, the risks. Psychedelics can be powerful, but they're not benign. High doses or unsupervised use can trigger psychosis, especially in people with a predisposition to schizophrenia. They can also cause lasting changes in perception or mood, a phenomenon called hallucinogen persisting perception disorder (HPPD). MDMA, in particular, has neurotoxic potential at high doses, damaging serotonin neurons. Addiction is another concern, though psychedelics like psilocybin are less addictive than substances like alcohol or opioids. There's also the risk of psychological harm. A bad trip can be deeply distressing, and without proper support, it could exacerbate anxiety or trauma. This is why clinical trials emphasize set and setting, using psychedelics in a controlled environment with trained therapists to guide the experience. My view is that psychedelics hold tremendous promise, but they must be studied rigorously and used responsibly. Micro-dosing, taking subhallucinogenic doses, is another area of interest, potentially offering benefits without the intense psychoactive effects. We need more data to understand long-term outcomes and optimal protocols, but I'm supportive of exploring these compounds as part of a broader toolkit for mental health. Huberman, that's a nuanced take, and it's exciting to think about how these compounds might complement existing treatments. One last question throughout your work, whether in the lab, the clinic, or writing your book projections, there's a thread of optimism about the future of psychiatry. What fuels that optimism, and where do you see the field heading in the next decade or two? Deisseroth, I am indeed an optimist, and that optimism comes from seeing the convergence of science, technology, and human compassion in psychiatry. My book Projections was an attempt to capture this, blending rigorous science with stories of patience and the hope that drives our field. I wanted it to be accessible to everyone while staying true to what we know and don't know about the brain. What fuels my optimism? First, the pace of discovery. Technologies like optogenetics, fMRI, and single-cell sequencing are revealing the brain's inner workings at an unprecedented level. We're starting to understand how specific circuits drive behaviors, which is the foundation for better treatments. Second, the growing acceptance of mental health as a public health priority. Stigma is still a problem, but conversations like this one are normalizing the idea that mental illness is treatable and deserves attention. In the next decade or two, I see psychiatry becoming more precise and personalized. We'll likely have biomarkers to guide diagnosis, allowing us to tailor treatments to each patient's biology. Neuromodulation techniques like next-generation VNS, DBS, or even optogenetics-inspired therapies will become more targeted, minimizing side effects. Psychedelics and other novel compounds will likely join the mainstream, used alongside therapy to enhance outcomes. Most importantly, I believe we'll continue to prioritize the human element. Technology is a tool, but it's the connection between clinician and patient, the trust, the shared journey that drives healing. My hope is that we create a world where no one suffers in silence, where mental health care is as routine as a checkup, and where science and empathy work hand in hand to relieve suffering. Thank you for this conversation, Andrew. It's been a pleasure to dive into these topics with you and share this vision with your audience. Huberman, thank you, Karl. Your work in the lab, the clinic, and through your writing is truly inspiring, and it's clear you're driven by a deep commitment to helping people. I highly recommend your book Projections to anyone interested in the brain, mental health, or the future of psychiatry. Thanks for taking the time to share your insights with us. Deisseroth, thank you, Andrew. I'm grateful for your platform and your passion for science communication. Keep up the great work.